So I'm talking about the management of Dupuytrens tonight. And I thought I'd start off with a few aphorisms and a couple of notes. So any fool can straighten a finger, but even a genius cannot currently prevent recurrence. And I think it's important to remember that. It's sometimes painful. And patients often get very cross about this because many patients will tell you that their Dupuytren's is painful, and yet we generally teach that Dupuytren's is not a painful condition. And Dupuytren's does not need to be treated with surgery. Dupuytren's contracture is treated, and that is really just a side effect of the underlying genetic condition. And for many patients, they live with a level of contracture that does not interfere with their function. And so it's not that they want a straight finger, but they want a finger that is acceptably straight. And we have to remember that a fully flexed finger is actually less of a problem than one that is locked or fixed in half extension. If we think of Bill Nighy, the actor, with his two fingers bent permanently down into the palm, he has managed to win multiple accolades as an actor with these fingers locked into his palm. Frequently, patients come to us because they don't know what is wrong, they don't know what the prognosis is, and they don't know what the options are. They want advice, and we offer them treatment. We need to remember that not everything needs treatment. And also, we need to remember that often for these patients, loss of flexion after surgery is more of a functional problem than their previous loss of extension. So what treatments are there? What things can you offer patients? Well, you probably don't want to offer them any of these. These are the things that you can find as untested treatments listed all over the internet. And I'm sure that I haven't got all of them. Allopurinol, interestingly, came from a time when gout and Dupuytren's were thought to be almost identical diseases. And there is now some evidence that there are links between them. I don't know of any evidence that sildenafil is of great benefit. Tamoxifen, we'll talk about in a moment, and Verapamil as well. So tamoxifen, interesting drug, and there's one randomized trial using tamoxifen at a very high dose, showing that it did inhibit the recurrence of Dupuytren's after surgery. The problem, sadly, was that this beneficial effect disappeared within 2 years of ceasing the tamoxifen, and the side effects are not insignificant. So not something that you should really be recommending to patients. Verapamil gel isn't available in the UK. It is available, I believe, in the United States, and I don't know about Europe. And if you can get it as a 15% gel rubbed into the affected palm and fingers, then it is reported to have some mild effect. However, I was unable to find any randomized controlled trials. So what things are currently being tested? Well, the RID trial from Oxford, repurposing anti-TNF for treating Dupuytren's disease, is a proper randomized trial. One could be cynical and say that it was a way of extending the patent on anti-TNF therapy, which has probably earned Oxford many millions of pounds, but I wouldn't ever dream of doing that. My worry about it is how it's going to be delivered. At the moment, it's being injected into the nodule, and that certainly reduces the systemic effect. But use systemically, I think, would be associated with risks that would really outweigh the possible benefits in terms of a seriously dangerous drug for a benign condition. So Shin mentioned collagenase, which we thought was the great hope of Dupuytrens at one point, until it became the great hope of smoothing out your buttock creases and your various other cosmetic problems. I remember that when this was first mentioned many years ago, and we got an email in the early days of email from the manufacturers, and it came to the consultant meeting, and it said, would we be interested in a medical treatment for Dupuytrens? And there was a sort of, nah, never going to work. And those that know me know that my view is jump onto it, see what it's like, and better to do a trial of something and prove it doesn't work than to allow it to get into the wild and let other people try and see if it works. So we used it, it worked. It's not perfect. It had significant risks. You can tear the skin, you can rupture tendons, you can damage arteries when you try to extend it. I certainly had patients who had bruising all the way up the arm and down onto the side wall of the chest, which was rather scary. We moved from doing the snap at 24 hours to doing the snap at a week. And the advantage of that was that the swelling that occurred in the week, or the first 48 hours after the injection, acted as a tissue expander, allowed the skin to stretch and soften, and then as the swelling went down, the skin stayed stretched. So when you came to snap the collagen, the Dupuytrens, at 7 days, you didn't get the skin tears. And that was very helpful. Unfortunately, as I said, it's been removed from worldwide use, apart from in the States, where it is highly expensive. But there are multiple other collagenases that have been characterized, and it wouldn't surprise me if we see another collagenase coming along in the future. So that's the things that are unproven, the things that are in trial, in drug treatment, and the things that have disappeared. What conservative treatment can you do? Well, splintage. There are papers all over the place of splintage, and we've got to differentiate between static splintage and dynamic. And really, after surgery, there is no evidence for static splinting. The paper by Christina Jerish-Herold really was a landmark paper in this, as a pragmatic paper of static splinting or no splinting after surgery. No significant difference between the splinted and the non-splinted groups, but a trend towards a better outcome with no splintage. And I think this resonated with many people. My impression is that our Nordic cousins haven't splinted for donkey's years. And certainly my view has been to move away from splintage. And this really pushed me away from splintage completely. I now don't even splint my dermo fasciectomies unless I have to. So other conservative treatment, radiotherapy. Anecdotally, and from the studies that are available, it does work. I'm not an expert on radiotherapy, and my view is that if a patient wants to discuss radiotherapy, I will put them in touch with a radiotherapist and leave it to the radiotherapist to discuss the pros and cons. My understanding is that there are different ways of delivering the dose, different sources for the dose of radiation, and I wonder whether that makes a difference to the outcome, because certainly some people seem to get very prolonged benefit whereas others report little, if any, benefit. I remember when radiotherapy was first suggested for treating Dupuytrens, those surgeons, especially plastic surgeons, who had an interest in or a previous experience of head and neck surgery were vehemently against it, remembering the skin damage from head and neck radiotherapy for intraoral cancer. But this is very different, much lower. And the skin does become dry. I think that's a universal. The skin is a sort of dry feeling, but I've certainly seen no problems with wound healing after radiotherapy. Not large numbers, because it does seem to reduce the rate of progression, but probably half a dozen, somewhere between half a dozen and 10 patients over the years. It doesn't cause regression of the Dupuytrens, so you need to discuss with your radiotherapist how you're going to manage any existing contracture. Are you going to do a needle apponeurotomy? Are you going to do open surgery? Are you going to do collagenase if you have it available? And then decide at the timings of the radiotherapy. What I've done is discuss with the radiotherapist when they want to give it, and then we will schedule a patient for a simple needle apponeurotomy, get the finger straight or the fingers, and then deliver them to the radiotherapist a few weeks later. So dynamic splinting. There are a number of studies of dynamic splinting, from simple occupational therapy splints to more complex. And one study showed that of the three groups, three different types of splinting, it did not influence the natural course of the disease after operation. But others, this one from Annelien Braun's, Luc de Smet, etc., showed that tension and compression orthotic devices can be used as a non-operative treatment of Dupuytren's disease in both early untreated and aggressive post-surgery. So there is evidence that dynamic splints will work and straighten fingers. In terms of surgically applied dynamic splinting, this, I think, was in some ways the landmark paper from Messina and Messina. This rather complex erection of Meccano, slightly more streamlined on the right-hand side, and they were able to confirm complete extension of the severely contracted fingers. My personal experience is that it's difficult to apply. I certainly found difficulty in getting these two pins into the fifth metacarpal on a reliable basis. I think I remember one metacarpal fracture from perhaps too many pins being inserted, and I know of other surgeons that also had fractures. This was in the days before we had small mini C-arms, so it may be different today, but something that demonstrated the utility of dynamic traction, but really hasn't stood the test of time. Perhaps of more interest currently is the Digit widget. Now, those of you that have been to the American Hand Society meetings will have seen the Hand Innovations stall and the multiple different devices developed by the team there. But this Digit widget is fascinating. You put two pins into the dorsum of the middle metacarpal. There's a jig for doing this. You do it under fluoroscopy. And then you have a wrap of lycra and sticky back plastic on the back of the hand. And this device is then applied to it. And these are mandibular bands used after intraoperative surgery. And as you can see, we take a post-surgery Dupuytren's, and over a period of 6 weeks, get it to a virtually straight position. And then at about 10 weeks, operate on the finger with a fasciectomy or skin graft, and then they recommend leaving it on for a further period after that. The beauty of this, of course, is that it's mobile, so the patient can still keep their movement whilst they've got it on, and it's very effective. I was fortunate to be able to get 2 of these devices some years ago, and I can confirm that they will straighten any finger. So I put one of them onto a patient with a 3rd time recurrent Dupuytrens of the little finger down into the palm, and over 8 weeks we managed to get it out completely straight, and then I went ahead with a dermo fasciectomy. Unfortunately, it's not available in Europe. There's no CE mark, so not currently available, but the concept is there. The problem with the dynamic traction, though, is that if you take the dynamic traction off before you do the surgery, it will very rapidly recur. Now, whether that's because the extensor tendon is incompetent, or whether you stretch the Dupuytrens and then it fights back against you when you take the traction off, I'm not sure. But fundamentally, it's a pre-surgery treatment or a post-surgery treatment, not an alternative to surgical treatment. So we've covered the various drugs that you can look up on Google if you are a patient. We've covered the various forms of conservative treatment and the pre-surgery treatment, but what else can you do? A needle apponeurotomy, Shinchin said that I have popularized it. I've certainly been keen on it. And it's one of those things that wasn't invented by surgeons, much to our discomfort. It was really, I suppose, invented by Baron Dupuytren. This is what he did. He did a needle apponeurotomy, but with a bijouterie, a jeweler's knife bijouterie. But it was reinvented or rediscovered by a group of rheumatologists in Paris. There was certainly a dermatologist in London doing needle apponeurotomy very successfully for many years, but was associated in the mind of most surgeons with a high risk of digital nerve injury, incomplete release, and complications. So I started doing needle apponeurotomy around the time of Collagenase, just before Collagenase became available and we started the trials. And really, it just took off. I think I had a patient that said they'd been to Paris, had had it done there. Would I do their other hand? And I said, oh, well, okay, let's give it a try. Started in the palm, and then gradually moved out into more complex cases. And patients just talked to each other. And within a few months, I had a queue out the door of patients wanting needle apponeurotomy, which meant that I had to get very good at it very quickly. Then Matt Venus and I prepared a video, one for patients on what they need to know, and the second one for surgeons. My view is that treat the palmar cords, and you can do this even in the context of doing a fasciectomy. You know that the palmar cords in primary disease will be superficial to the transverse fibers. The nerves are going to be safe. And so with an anesthetized patient, just before you start doing the fasciectomy, practice your needle apponeurotomy in the palm, see the benefit it gets, and then go ahead with your fasciectomy, exploring where you've done your needle apponeurotomy, confirming the release, or seeing how you've missed parts of it. And then as you get better at it, you could perhaps do needle apponeurotomy in the palm for a complex disease patient prior to surgery, help straighten the finger out partially, and then bring them in for a more limited fasciectomy in the finger, for example. And then you can work your way out towards the PIP joint and even towards the DIP joint. On this slide, you can see a range of needles. I use blue needles almost universally. I don't use green needles except occasionally in the palm. I think they're slightly too big. And I use orange needles at the PIP joint and beyond, just because they're shorter and they're more precise. Be careful that you don't get given needles that are too long. If you get a blue or orange needle that's too long, then it will be too whippy and you won't actually get feedback from the tissues as to what you're doing. Choose your portal site for the needle apponeurotomy with care. You don't want to do it where the skin is adherent to the underlying Dupuytren's cord. If you do, you'll get a skin tear because there's no possibility of extension. So what you want to do when you're starting is to put tension on the finger and look for where the skin remains pink. So stretch the finger out, get most of it to blanch, and you'll see where the skin is not under tension by it remaining pink, and that's where you put your portal. You can start proximally or distally. I prefer to start distally. That means that if I do happen to anesthetize the digital nerve, when I come to the next most proximal portal, the nerve will not be anesthetized at that point, and I'll still get an electric shock from sensation in the patient if I touch the nerve. But that is relatively rare. The important thing is to only have a short part of the needle in the finger so that you know what you're doing. These pictures were drawn by a medical student who was working with us and show the various methods. If you've got a lovely mature Dupuytren's cord, then simply putting the cord under tension and pushing the needle into the cord will start to cut it. And you'll sometimes feel the cord just giving way as you push the needle in. And it's a lovely feeling. And you can feel the finger straightening out each time you do it. And this is what the French rheumatologists were doing. They were simply pushing the needle into the cord hundreds of times. But frankly, it doesn't work for every cord and it gets boring very quickly. And we're surgeons, so we can do better. So the next technique that I developed was to stroke the cord. If you put the tip of the needle on the very surface of the cord and just slide it backwards and forwards, so you're just tilting the needle side to side, no pressure at all, then it will just scratch its way through the cord. I call this the zen of needle apponeurotomy. There's no force to it, it just flows. And again, if you aren't just feeling that scratchy nature of the cord, stop. Needle apponeurotomy is supposed to be safe. It's a minimally invasive procedure. Stop whenever you're not sure what you're doing, not sure what you're cutting, and you're not sure where the needle is. Any one of those, if you don't stop, will lead you into disaster. So stroking the cord, very helpful. The next one is what I call the slice. Now, if you've got a cord that is thin, then you can't stroke across the top of it. But if you put the needle down the side and then just put a little bit of tension on the needle so that as it comes up, it flicks, then it will start to cut through a narrow cord. And that's what we're trying to demonstrate here. So you can see that I've got a little bit of bowing on that needle, not very much, just a slight amount, so that as it lifts up, it will slice its way across it. And you just keep on repeating that, doing it from each side in turn until you feel the cord go. And then manipulation. And this is either the most scary part of needle apponeurotomy or the most enjoyable part of needle apponeurotomy, or both. You get to the point where you know that you've got through the vast majority of the cord with your needle. You know that you're not really feeling clearly anymore, a cord to be cut, but it hasn't quite come straight. Is this the joint that's stiff, or is it still cord? If you can't feel a defect in the cord, then there's still some remnants of the cord. And if you isolate the joint, so if you're doing a PIP joint, flex the MP joint, and then straighten just the PIP joint, you will get this snap, as we call it. If you're lucky, it will sound like a ripe carrot just snapping in half, and everybody in the room will jump. Otherwise, it will just ease out. I don't think there's any difference in the long-term outcome between the two. And then as soon as you've done that, you'll be able to feel a defect between the ends of the cord. And when you stretch the finger, the skin that wasn't under tension and stayed pink when you stretch the finger will now go white, showing that you've taken up all of the elasticity in the skin. So that's needle apponeurotomy. For me, it's one of the most enjoyable parts of Dupuytren's treatment. It's simple, it's safe, and I always say to patients that if I can't feel what I'm doing safely, or I get lost in the finger, we will stop, we will reassess, and we'll either go for surgery or the patient can live with what we've already achieved. I'm not there to get perfection in complete extension. I'm there to get an improvement with minimal risk and minimal damage. So let's move on to the more traditional surgery. And there's a variety of these, from segmental fasciectomy, limited fasciectomy, and even radical fasciectomy. Now, radical fasciectomy has really fallen out of favor, very much like most other forms of radical surgery. And I look at almost all forms of surgery as going through this evolution from pre-anesthetic days of minimal surgery that was often very fast, get the minimum necessary done. And then with the introduction of anesthesia, we saw surgeons moving into radical surgery. So with breast cancer, we moved from mastectomy to the radical to the Holsted's mastectomy, and then we realized it didn't work. And so we now see things changing back, and with chemotherapy and radiotherapy, we can move back to more limited surgery, but equal cure rates, or better cure rates even. And similarly with Dupuytren's, we went from small treatments with Dupuytren, the introduction of anesthesia allowed fasciectomy, and then radical fasciectomy, where the whole of the skin of the palm was elevated and the fascia excised en bloc. Often associated with real high incidence of wound necrosis, long-term healing, but also associated with very highly successful treatment. My grandfather had a radical fasciectomy, probably back in the 30s or 40s, healed perfectly, never had any long-term problems, never had recurrent Dupuytren's. Thankfully for me, it didn't pass down the family. And at the moment, touch wood, I have no signs. But we have to think, what do we mean by Dupuytren's? What do we think of the disease process? Are we looking at a disease of specific parts of the fascia, in which case we want a narrow margin around the cord? Or are we seeing this as a disease of the whole fascia, in which case we want a radical excision? We want to look at recovery for the patient, the time to recovery versus the recurrence rate. And there's very little information on which to base any decisions. We talk about the Dupuytren's diathesis, but we don't really know what that means. And one of the problems from needle apponeurotomy, and those of you that do needle apponeurotomy and do it regularly and have been around for the 27 years that Shinshin reminded me that I've been a consultant for, thank you, Shinshin, will know that multiple needle apponeurotomies will lead to more complex disease. And so whilst needle apponeurotomy is, I think, excellent and patients like it, you have to be aware that if you've done it 2 or 3 times or even 4 times in a finger, when you finally come to do the fasciectomy, you will have a long job. It will be complex, you'll have more retrovascular cords, you'll have more spiral bands, and you'll be working hard for your money. Get 2 surgeons together to talk about Dupuytren's and you'll probably end up with 3 different approaches. I personally like the Makash and Skoog, but then I'm old-fashioned. I used to think that the Brunner approach was not a good approach for Dupuytren's, but many of my colleagues who I really respect have used the Brunner incision and made it work for them. The lateral approach, Donald Samet is, I think, very much in favor of the lateral approach. And I think it does have its place. I think if you've got a unilateral cord with an experienced surgeon, then distal to proximal dissection through a lateral incision can be very effective. But if you're an inexperienced surgeon, then I would still recommend the Skoog approach. I think it's more extensile in its exposure than the Brunner, and the Makash. Now, why the Makash? And it's one of those exposures that comes and goes in and out of fashion. For those of you that aren't aware of what the Makash is, it's a transverse incision in the palm, somewhere around the distal palmar crease. And you just open it up, raise your skin flaps, and then carry on with either a Brunner or a Skoog, and you leave it open at the end of the procedure. You have to warn the patient that you've left a great big hole in the palm of their hand, otherwise they and your nursing staff get very upset later on when they come for their first dressing change, but it will heal in about 10 days to a fortnight. And fascinatingly, it leaves virtually no scar. You cannot see where it has happened. I think it has 3 advantages. Firstly, it allows you to have a drainage portal so that you won't get hematomas. I know that they aren't common in Dupuytren surgery, but it just gives me that little bit of extra sleep at night. Secondly, it takes the tension out of the fingers so that you get a little bit of movement of the web spaces into the fingers because all of this skin has moved forwards. So I think it aids extension of the finger at the end of the procedure. And finally, I think it takes tension off the sutures so that when you ask the patient to extend their fingers, they don't get that tension from the sutures. But finally, on this slide, we've got to talk about what you're going to do with the neurovascular bundles. Now, the neurovascular bundles we know are collateral damage in Dupuytren surgery. Dupuytren's is not about the neurovascular bundles, but we have to know where they are in order to excise the Dupuytren safely. And every trainee is told that they have to look out for spiral bands, and that if they cut the digital nerve whilst through a spiral band, they will be damned forever and drummed out of hand surgery, and it will be a big black mark. Well, my view is that actually doing Dupuytren's, I just don't want to see the neurovascular bundle unless I have to. So in primary disease, I will be doing everything I can not to see the neurovascular bundle. The neurovascular bundle's surrounded by fat. It's under no tension in Dupuytren's disease. So even if you push your knife against the neurovascular bundle, you won't damage it. And if you can leave that perineural fat alone, it will prevent scar tissue forming around the nerve and mean that when you come to do your revision surgery, you will still have a virtually pristine nerve to dissect out a functioning artery. If you make it your life's work to demonstrate the neurovascular bundle, even in primary cases, you will be very sad when you come to do the revisions because it will already be scarred. So know where the neurovascular bundles are, but just leave them there. Let sleeping dogs lie. And then closure. Well, there's as many different ways of closing a wound as there are different surgeons. Z-plasty or V to Y. Clearly, as a proponent of the Skoog approach, I like Z-plasties. One single large Z-plasty in the proximal compartment. Nothing fancy. Don't move skin from the palm into the finger, so it's not formed on the palmar digital crease. It's formed in the middle of the proximal compartment. Then close all gaps or allow secondary healing. When I was a young surgeon, then I was taught that you had to close all gaps. So everything had to be closed. And if the gap couldn't be closed, you had to put a skin graft on it. And then I think coming from the congenital hand surgery world, we had the concept of secondary healing, especially for syndactyly release, where people were simply joining the apices of their zigzags. And now I'm really very happy to leave gaps in Dupuytrens. If I will close the apices, I might do a running stitch, but if it's tight, just leave it. I use absorbable sutures. I think there's a number of reasons. Firstly, patients like absorbable sutures. Patients dislike having sutures removed. And if you've ever had sutures removed from a slightly gooey wound, it's painful. Secondly, in times when nurses in clinic are in short supply, run off their feet, why give them extra work? It takes hours sometimes to take sutures out of Dupuytren's patients. Absorbable, doesn't matter. Dressings, whatever you like. Plaster of Paris, no. Splints, no. Further dressings, whatever you like. Increasingly, I'm thinking that what we should be doing to these patients is treating them like either burn scars or hypertrophic scars, and that we should be in the immediate post-operative period, once everything's healed, putting them into compression orthoses, compression gloves with silicone inserts to control scarring. But that's something that when we have limited therapists is again difficult. And then we come on to the big daddy of them all, the dermo fasciectomy. So Andy Logan in Norwich produced a lovely paper a number of years ago showing that a well-performed dermo fasciectomy will reduce recurrence more than anything else. And here we can see a series of photographs. There's the Dupuytrens, the skin graft sutured into place, the tie-over dressing, and then final appearance. And it works. It's a brilliant treatment. And there are some people who think that it should be done fairly early. I prefer to keep the patient's natural skin, and so I will often keep it for the third revision. But if I get rapid recurrence, so if I get recurrence after surgery at 3 to 6 months, which does happen. So there's a feeling, I think, amongst surgeons that if they see that rapid recurrence, the patient that you've done a beautiful operation on, and they've come back 3 months later to your clinic and the finger's back down again. Oh, what do I do? They're the ones to do a dermofasciectomy on. Even if it's the first recurrence, just do a dermofasciectomy. Full thickness versus split, it's got to be full thickness. There's papers about using Integra and then a split skin graft on top, but just do a full thickness. I use the antecubital fossa. It's thin, mobile skin. There's plenty of it. It leaves a scar in the lines of election that's invisible. I think taking full thickness grafts from the side of the forearm leaves a horrible scar. It's a tight wound. It's hypothenia eminence equally, but even more. So for me, full thickness antecubital fossa. If you want to show off how good you are, then you take it, leaving the rete pegs behind so that you can see the tracery, and you don't defat. A couple of fat globules on your skin graft will make no difference to the take, whereas taking your scissors and meticulously taking off every bit of fat from your skin graft will certainly crush and damage it. So sharp knife, lots of tension, and lift the skin graft in one piece. But the standard description of dermofasciectomy is to excise the original scar. But then you're throwing away tissue. And my personal preference that I've done for 27 plus years is what I call the Stilwell technique. Those of you that work in the north of England, or certainly the northwest, may remember John Stilwell, a plastic surgeon who taught me this technique during his time and my time at Wrightington. It's a difficult technique. It's technically demanding. It protects the PIP joint particularly, and it comes, I think, from the concept of burn scar management. And this is a picture that I found of the management of burn scar on a neck, where we don't cut out this whole scar. We simply incise it, let it retract, and then fill in the gap. This is a picture of a burn scar in a finger in a child, and you can see the similarity to severe recurrent Dupuytrens with this shortage of skin. And here, traditionally, you would open this up, you would release these flaps of scar tissue back to the midlateral line, and then you would inlay a graft. What I do, and I don't have a picture of this. I've gone through all my slides, and it's something that I do so routinely that I've never thought to photo it or to photograph it. So if you start in the middle of the middle phalanx, at the midlateral line, and draw your incision right down into the palm, and you want to be proximal or just proximal to the edge of your previous scar tissue, and then down the other midlateral line. By being just proximal to your level of scar tissue, this allows you to go down and find your neurovascular bundles in good tissue. And then you lift this whole flap of skin, scar, Dupuytrens, whatever, off the neurovascular bundles, off the tendon sheath, just sliding it distally. Now, this looks as if it's going to be a massive flap that is far more than one-to-one. It's going to have very poor blood supply, and it's made of scar tissue and Dupuytrens. Well, it does in this picture. But if you imagine doing it in this hand, it's going to be a very short piece of tissue. It is virtually going to be one-to-one by the time you've raised it, and it always survives. If you're worried, you can let down the tourniquet and inspect the proximal edge of it, and it will bleed. The big advantage is that as you dissect this out and you start releasing the PIP joint and you open the tendon sheath, as we always end up doing, and then you're worried about putting your skin graft on it, will it take over the tendon? This flap always just sits over the PIP joint crease. And then you put your big skin graft down in here. So you have the advantage that you haven't thrown any tissue away. You've kept and used that tissue, and you've used it where your skin graft will have the poorest take. So it's demanding. It's not something to jump into unless you're very happy with dissecting out along the neurovascular bundles. But I think it actually gives a much better result in terms of dermofasciectomy and is less wasteful. So what are the last rites of Dupuytren's? Amputation. And sometimes it is the single best option. Sometimes just amputate the finger. Amputate the finger, keeping a long dorsal flap, and fold that dorsal flap down into the palm, resurfacing previously scarred tissue in the palm. Dorsal tissue doesn't have Dupuytren's. Well, yeah, it does, the pads, but effectively it doesn't. So folding it down into the palm gives you lots of skin and gives you a fire break, if nothing else. The other one that people don't think about, but which I think can be very useful, is to turn a three-joint finger into a two-joint finger. And you can do this in two ways. What I prefer to do is a PIP joint excision arthrodesis. And what I do is open from the back, so you're going through virgin territory, and you excise proximal phalanx and middle phalanx until the finger will come straight again, and then you simply put a plate on it, reef your extensor tendon, close up, and you've shortened the finger, usually by about a phalanx in length, but you've got a finger that is straight, all the Dupuytren's is relaxed, and it's got one joint at the appropriate place for the finger to function. An alternative that I have come across is that in a situation like this, you'd take out the middle phalanx, keeping all of the collateral ligaments. So you keep the collateral ligaments at the DIP joint on the distal phalanx and at the PIP joint on the proximal phalanx. And you bring the distal phalanx to sit on top of the proximal phalangeal head, repair your collateral ligaments, reef your extensor tendon, and again produce a two-joint finger of a shorter length, but removing the contracture. I think that's more complicated than my one, but my one has an occasional non-union rate, so two options. One of the big problems, I think, in Dupuytren surgery is consent and the complications. This is the list of expected complications from limited fasciectomy surgery in the DISC trial. Amputation, arterial injury, bleeding, complex regional pain syndrome, delayed healing, infection, instability, nerve injury, pain, paresthesia, scar pain, scar edge necrosis, carpal tunnel syndrome, tenosynovitis, and trigger finger. So if you're not telling patients about these risks, then you aren't telling them about what a nationally funded, ethically approved study considers expected complications. Mention of trigger finger reminds me of another slide, which I thought I had, or a point that I've missed out, which is that whilst Dupuytren's may be painful, not all pain in Dupuytren's is Dupuytren's. Think of other things. And my colleague Dan Armstrong has really brought home to me in his discussions that a tender nodule in the palm in the line of the ring finger is frequently a tendon sheath and A1 pulley rather than a tender nodule. And Dan has had great success with some of these patients with a steroid injection into the tendon sheath rather than injecting nodules. And that reminds me, we've not talked about injecting nodules, probably because I don't like it and I think it's a waste of time. And I think it's very, very painful. And that seems to have brought me to the end.